So next we're going to talk about some intraop considerations. When it comes to equipment, especially design tables or even two regularly sized OR table may be required for safe anesthesia and surgery in these patient population. Regular OR tables have a maximum weight of about 200 kilos, but OR table capable of holding up to 455 kilos are available, and those are the bariatric tables. Strapping the obese patients to the OR table in combination with the bean bags, help keep them from falling off the OR table, and this can be a huge problem in the laparoscopic or Da Vinci rooms. Supine position causes ventilatory impairment and IVC and aortic compression in obese patients. FRC and oxygenation are decreased with supine position, as you know. Head down position often required during the bariatric procedure, even worsens the FRC, and should be avoided if possible, but quite often is not. Simply changing the obese patient from a sitting to supine position can cause a significant increase in oxygen consumption and cardiac output. The head-up position, reverse Trendelenburg position, provides the longest safe apnea period during induction of anesthesia. The extra time gained may help preclude hypoxemia if intubation is delayed, especially if it's a difficult intubation patient. Both intraop PEEP and reverse Trendelenburg position significantly decrease the alveolar arterial oxygen tension difference and increases total respiratory compliance to a similar degree, although the head-up position results in lower airway pressures. Both PEEP and the reverse Trendelenburg position can decrease cardiac output, though, which partially counteracts the beneficial effects for the oxygenation. Prone position, rarely required in obese patients, hopefully, should be correctly performed with freedom of abdominal movement to prevent detrimental effects on lung compliance, ventilation, and arterial oxygenation. Lateral decubitus position allows for even a better diaphragmatic excursion and should be favored over a prone position if that's a choice. Particular care should be paid to protecting pressure areas because pressure sores, neural injuries, and rhabdo may occur in this patient population at a higher rate. Brachial plexus and lower extremity nerve injuries are frequent in this patient population. Carpal tunnel syndrome is the most common mononeuropathy after bariatric surgery. Other reported neuro complications include encephalopathy like Wernicke, optic neuropathy, and myelopathy associated with B12 and copper deficiencies. Monitoring the surgically obese patient poses significant challenges. Proper sizing of the blood pressure cuff and choice of location is important. Blood pressure measurements can be falsely elevated if a cuff is too small. Cuff of a bladder that encircles a minimum of 75% of the upper arm circumference, or preferably the entire arm, should be used. Forearm blood pressure measurements with a standard cuff overestimate both systolic and diastolic blood pressures in obese patients. A lines can be indicated for the super obese patients, not only because those patients may have cardiopulmonary disease, but also for those patients in whom you can't use a blood pressure cuff properly. Central venous catheterization, though not routinely needed, may be required for IV access in some patients when we have inadequate peripheral access or periodic fluid management. The central venous catheters, PMA catheters, and even TE can be used selectively in these patients, especially if they have significant cardiopulmonary disease or they need to go extensive surgery. Adequate pre-oxygenation is vital in these patients, as you all know, because they can get rapidly, desaturate rapidly as soon as they lose consciousness because of the increased oxygen consumption, decreased FRC, which is what makes them desaturate so quickly. Having the patient voluntarily take 4 vital capacity breaths with 100% oxygen within 30 seconds of anesthesia induction has been suggested as being superior to the recommended 3 minutes of 100% pre-oxygenation with normal tidal breathing. Use of the reverse T position, the reverse Trendelenburg position, or semi-sitting position at about 25 degrees provides the longest period of apnea without development of hypoxia during the induction. The extra time gained, though, may help preclude hypoxemia in difficult intubation patients. Pre-op use of the non-invasive positive pressure or application of PEEP during induction would also combat the pre-induction hypoxemia. The reverse Trendelenburg position may also help prevent pulmonary aspiration of gastric content as well as hypoxemia. The obese patients are more likely than the non-obese patient to present with difficult mask ventilation and probably intubation, especially if they have a short, thick neck and sleep apnea. If a difficult intubation is anticipated, don't second guess yourself when it comes to awake intubation. During an awake intubation, sedative hypnotic medication should be reduced to minimum. Sedation with dexmedetomidine during awake intubation provides fairly good anxiolysis and analgesia without respiratory depression. Hypoxia and aspiration of gastric content should be prevented at all costs during endotracheal intubation. And you should always ask an experienced colleague who is in the OR or immediately available during induction, and airway management can be helpful to help with the mask ventilation and attempt of intubation. Also, a surgeon capable of accessing the airway surgically should be rapidly available. The ramp position elevates the obese patient's upper body and improves not only the laryngoscopic view compared with the standard sniffing position, but also minimizes the risk of hypoxia. Towels or folded blankets, it's my favorite thing to do when it comes to putting the patient in a ramp position. The objective of this ramping position is to bring the airway in a aligned position, and if you can see the tragus at the same level of the sternal notch, you're in the right position. Just to have the video laryngoscope, laryngeal mask airways, LMAs, and fiber optic bronchoscopes available in the room if you suspect any difficulty. And the videoscopes have been proven to be efficient tools in minimizing the need for awake intubation. Multiple laryngoscopic attempts and repeated attempts at intubation are consistent with increased airway and hemodynamic complication. And the ASA clause claims that it also supports the recommendation to limit the conventional intubation attempts to 3 before moving to a different strategy. LMA can be useful for temporarily achieving airway patency in patients with difficult mask ventilation and intubation, or for placing a definite endotracheal tube, or by using an intubating LMA. Quite often when I'm by myself and I have a patient with BMI of 70, 80, I don't even attempt mask ventilation. I just put in an LMA for mask ventilation, and when the rock is kicked in, I just take the LMA out and intubate. Concerns for hypoxia, gastric regurgitation, and aspiration during induction and intubation justify the common use of rapid sequence strategies. So, GERD is relatively common in this patient population, and the incidence of regurgitation and severe pneumonitis in case of aspiration is increased. Findings that the non-premedicated, non-diabetic, fasting obese patients with no significant gastroesophageal pathology are unlikely to have high volumes, low pH gastric content after routine pre-op fasting suggest that routine pre-op fasting guidelines may be safe in obese patients. But in any case, the use of an RSI as opposed to standard induction technique should be considered. Larger doses of induction agents may be required because Blood volume, muscle mass, cardiac output increases linearly with the degree of obesity. Any of the commonly available IV induction agents may be employed after taking into consideration the problems particular to the individual patients. An increased doses of SUX is necessary because of an increased activity of acetylcholinesterase. And interestingly, myalgias is not frequently seen following succinylcholine in the morbidly obese patients. SUX, due to its rapid onset and limited duration of action, is highly recommended for the intubation in this patient population and works quite nicely. Continuous infusion of short-acting IV agents like propofol or any other inhalation agents or combination may be used to maintain their anesthetics. Desflurane, Sevo, and Iso are minimally metabolized and are therefore pretty useful agents and result in hemodynamically stable maintenance. The use of nitrous, despite its rapid elimination and analgesic properties, is limited because of the high oxygen demands in this patient population. Short-acting opioids are preferred in obese patients to provide adequate analgesia but avoid post-op respiratory depression. Remifenol and fentanyl, carefully titrated to clinical effects, are the most common choices. Dexmedetomidine, as you know, the alpha-2 agonist with sedative and analgesic property, has no clinically significant adverse effect on respiratory and attractive anesthetic adjuncts in this patient population. It also reduces post-op opioid analgesic requirements. Profound muscle relaxation is important during the laparoscopic bariatric procedures, in particular to facilitate ventilation and maintenance of adequate working space for the surgeons. Also facilitate extraction of excised tissue. Collapse of the pneumoperitoneum and tightening of the patient's musculature around the port sites are early indications of inadequate muscle relaxation. Vacuronium, brachyronium, and cisatracuronium are all useful non-depolarizer blocking agents for maintenance of muscle relaxation. Pneumoperitoneum should not be increased above the pressure of 15 centimeter water, since intraabdominal pressure of more than 20 or greater can cause vena cava compression and decrease cardiac output. Cephalad displacement of the diaphragm and carina from a pneumoperitoneum during laparoscopy can cause a firmly secured ventricular tube to displace into a mainstem bronchus. So always be careful with that when you drop your saturation after pneumoperitoneum. Excess adipose tissue may result in visualization of peripheral perfusion difficult, making fluid balance difficult to assess. Blood loss is usually greater in the obese patients and a non-obese patient for the same type of surgery because technical difficulties of accessing the surgical site, and they usually require a bigger incision and more extensive dissection. So fluid management is particularly challenging in this patient population. Normal volemia should be the goal, not only to avoid hypovolemia, but the associated increased hemodynamic instability and incidence of post-op nausea, vomiting, but also to avoid hypervolemia associated with the decompensated CHF, peripheral edema, and pulmonary complications. Rapid infusion of IV fluids should be avoided because of the potential pre-existing CHF in the patient population. And especially during laparoscopic bariatric surgery, urine output does not correlate with the rate of intraop fluid administration. And the total volume of fluid infused does not seem to affect the incidence of post-op rhabdomyolysis. Excuse me. Obesity makes the selection of ventilatory setting challenging, since increasing the weight doesn't imply proportional growth of the lungs. Obese patients are more likely to be exposed to higher tidal volumes because of miscalculation of predicted body weight or ideal body weight, and also to higher airway pressures because of increased respiratory system compliance. Although similar ventilatory parameters in non-obese patients can be used, it may be difficult to maintain plateau pressures of less than 40 or 30 centimeter water. Greater inflation pressures may be tolerated in this patient population because the extra adipose tissue partially attenuates lung overdistension. But regardless, tidal volume should not be more than 8 ml per kilo, since higher tidal volumes often no added advantage during mechanical ventilation of the morbidly obese patients under anesthesia. If we increase the tidal volume more, they just increase the peak inspiratory airway pressures and expiratory pleural airway pressure and lung compliance without improving the oxygenation. No specific ventilatory mode has been found to be significantly better for oxygenation and CO2 clearance in the obese patients, although pressure control modes have in some cases been better in improving oxygenation. PEEP with or without recruitment maneuver is the only ventilatory parameter that has consistently been superior in improving the respiratory function of obese patients. And usually moderate PEEP of at least 10, particularly after a recruitment maneuver, has been found to be efficient in ventilatory technique in reducing post-op atelectasis. Different methods for performing recruitment maneuvers exist. A simple one is a series of 3 short, about 6 second long inflations with a pressure control ventilation to administer a large tidal volume by reaching an inspiratory pressure of 40 to 55 centimeter of water. And these higher than usual airway pressures may be needed to compensate for the decreased chest wall compliance. My favorite recruitment maneuver is to put the PEEP to 20 for about 3 to 4 minutes, as long as their blood pressure tolerates it, and then up the PEEP to 10 to 12 for the remainder of the procedure. Attention should be paid to avoid decrease in venous return and cardiac output when you increase the PEEP, though. And although they've been adequately tolerated in normal volemic obese patients, inspired oxygen fraction, or FiO2, should be titrated to the minimum level that reassure acceptable oxygenation levels, but avoid reabsorption atelectasis. And some experts recommend the FiO2 to be kept lower than 0.8 in the obese patients. Prompt but safe tracheal extubation reduces the likelihood of the morbidly obese patient to become ventilatory dependent. This is especially important in patients with underlying cardiopulmonary disease. Similar to the recommendation during induction, during emergence, the patient should preferably be extubated in the semi-recumbent position. This is what I call the Chris Chase style. In some institutions, policies have been developed to mandate presence of at least 2 anesthesiologists at emergence and extubation of the morbidly obese patient. Supplemental oxygen should be administered after extubation. Some authors recommend an observational period of at least 5 minutes in the operating room, which I think is quite reasonable. Lifting devices like the hover mats, that patient transfer devices, and gantry-style mechanical lifting devices that use slings are very useful in transporting obese patients. Monitoring of adequacy of ventilation and oxygenation is extremely important in this patient population. The obese patients presents a higher risk of sedation-induced respiratory depression, so careful titration of the benzos, opioids, and propofol is mandatory to avoid hypercapnia and or hypoxemia. Hypoxemia may require unplanned intubation, so a thorough airway examination and prep for intended airway management is critical, even when you're doing a MAC for this patient population. The prevalence of closed malpractice claims related to adverse respiratory events during MAC cases is increasing compared to respiratory complication or airway management complication encountered during general anesthesia, which are decreasing. In a closed claim analysis by Bananker, obesity and suboptimal monitoring of pulse ox and tidal capnography are both very significant key factors in these adverse events during MAC. Neuraxial techniques, the spinal, epidural, or CSC, and peripheral nerve blocks used alone in combination with general anesthesia are becoming more and more anesthetic technique of choice in the obese patient. Several studies have shown that the efficacy of regional technique in reducing opioid-related complications, but there are several distinct advantages. There is minimal or reduced manipulation of the airway, administration of fewer medication with cardiopulmonary depression. There is reduced risk of post-op nausea vomiting. There is better post-op pain control and improved general post-op outcomes. When epidural anesthesia is combined with general, time to tracheal extubation may be reduced in this patient population. But utilization of regional anesthesia is accompanied by increased risk of lung failure in obese patients compared to those that are not obese. And failure often due to technical difficulties like the patient's size and difficulty locating the anatomic landmarks. Additionally, these patients also experience an increased risk of complication. Neuraxial anesthesia can produce serious cardiopulmonary alteration in the obese patients undergoing any type of surgery. Because pulmonary mechanics, lung volumes, FRC, oxygenation, ventilation are already compromised preoperatively in these patient population, supine and Trendelenburg position during neuraxial anesthesia can lead to a further worsening of the lung volumes, including a reduction in FRC. FRC may fall below closing capacity, promoting small airway collapse, atelectasis, ventilation perfusion mismatch, and hypoxia, especially during supine and Trendelenburg position. It is often helpful to measure the oxygen saturation in the sitting and supine position to indicate a degree of pulmonary reserve before initiating any sort of neuraxial anesthesia. In addition, these pulmonary concerns, there are cardiovascular changes that warrant careful monitoring. The excess weight of the abdominal wall can compress the vena cava, causing decreased cardiac preload, reflex tachycardia, and decreased cardiac output. Despite the complications, use of the neuraxial techniques can offer significant advantages when compared to general anesthesia alone, particularly because it may permit utilization of fewer opioids. The IV opioids can be quite dangerous in this patient because of increased sensitivity, higher risk of hypoxia, high incidence of apnea, and increased incidence of adverse respiratory events after surgery. Administration of patient-controlled anesthesia, the PCA, respiratory depression in some obese patients. The ASA has published multiple guidelines for the care of the patients with OSA and recommends that regional anesthetic techniques should be considered or reduced to eliminate the requirement for systemic opioid, especially with patients with sleep apnea. Proper positioning is an important step in placement of any neuraxial technique. Spinal epidural placement in the sitting position will typically be a little bit easier, and the patient's back should be parallel to the edge of the bed to prevent lateral needle deviation away from the midline. Typically, if I can't find the midline, I can't use a needle to find the midline, I like to use the ultrasound to mark the midline. Single injection spinal anesthesia is a popular technique, but there are several concerns, especially technical difficulty, exaggerated spread of local anesthetic, hypertension, inability to prolong the block, especially in obese patients. Spinal anesthesia is reasonable if the airway exam is reasonably normal, and there is no significant cardiopulmonary disease, and the surgery is expected to last less than 90 minutes or so. It's often easier to insert a spinal needle when a large gauge stiff epidural needle is used as a guide, a smaller flexible anesthesia technique. And typically, if I suspect a difficult spinal, I just use a CSC technique. Decreased CSF fluid volume have been confirmed in obese patients by imaging studies. Though there are other studies that report no clinical differences in the height of sensory block after hypobaric and hypobaric spinal anesthesia in obese patients compared to non-obese patients. Spinal anesthesia should be performed with caution, with the consequence of excessive blockade, prolonging surgery, and hazards of intraop induction of general anesthesia.